and I appreciate the chance to talk to the whole group today. And what I'm going to talk about is reversing cognitive decline through a precision medicine approach. And we are launching a randomized control clinical trial in this space and are recruiting patients as we speak. So if you have any patients at the end of this talk that you would like to enroll in the trial, definitely do reach out and we'll give some information on how to enroll patients in this. But I've been working with the medical students and residents at Hopkins for a couple of decades. And one question that I ask them almost all the time when we do talks is, how many of them have seen durable remission or reversal of complex chronic conditions with their patients? And unfortunately, very few of them do raise their hands. And obviously, with this group, I know that everybody can raise their hands and say that they have seen improvement. But I think what we're really talking about here is with neurodegenerative disease is one of the conditions that's really hardest to make durable remissions for. And what I'd like to really do is tell a little bit of a story today on where I think the research is, and I think it is moving in pretty exciting directions, as well as some clinical experiences that I've had in trying to help patients with this. So, my background in medicine has been as a general internist, and I was a general internist. I trained at Penn and at UCSF, and really much more with a health systems and health policy background, and really trying to improve the health system for patients with complex chronic conditions. That was really sort of the theme of my career. I started off in working in federally qualified community health centers and was able with them we actually got together as a group. We got together with Johns Hopkins and we basically formed a Medicaid HMO that basically the profits for the Medicaid HMO went back to care for the uninsured. And so probably over the next 2 decades, a couple $100 million of care for the uninsured in the state of Maryland. I went to McKinsey & Company as a partner, really working with a lot of healthcare systems and really trained on getting the right system lens. And so this is just a graph of some of the systems that we would think about for different types of problems. And the problems might be, working for the governor of Tennessee and saying, how do we prevent Medicaid from eating up every incremental dollar in the state budget? Or it might be working with the National Health Service to say, what's the right level of organizational structure that we should have to bring in sort of clinical decisions on how budgets should be allocated. And I came down to Miami down in 2011 to really build up GenCare, which was a subsidiary of ChenMed. And at the time, the challenge was, how do you take a Medicare Advantage model and scale it to multiple states, 26 centers within, a year and a half, and try to get some good results. And getting that lens right was really important. The answer to that question was really getting the people dimension right, getting the hires of physicians right, getting some of the mindsets of the staff right, and following all of the Medicare Advantage rules. I decided to, about 7 years ago, get a little bit more into the world of integrative medicine because I became convinced that the impact of the environment on the exposome and the exposome on people were really the big source of chronic disease that was being missed. I spent some time at Johns Hopkins, trying to figure out the direction of Resilier Health. And there was a couple of sort of profound meetings I had with a number of the neurologists sort of there that led us to really focus on brain health. But I come to this as really much more of a systems person, trying to always figure out what's the right system and what's the right lens to analyze the problem. What I'm not is I'm not a good molecular biologist. So even though this is the interactome of the amyloid precursor protein, I'm not going to be the person that really shines light on that in a different way. So what I'd like to do today is really talk about the short history of research in doing multimodal prevention, a little bit of the results of the proof of concept trial in how to reverse cognitive decline, really talk about the randomized clinical trial that's coming up and the framework that we're using, as well as some clinical insights that we've had from implementing this framework. So I'm going to start off with a case study of somebody who came in last year, about a year ago. So this is a person who was in their 50s. She was a Marine, and she had had significant exposure to toxicants and burn pits from multiple tours of duty in Iraq and Afghanistan. In 2013, she started to present with neurological signs, tremors in the left hand, and migraines. She then progressed to aphasia and word finding issues. And then in 2019, she saw her first functional medicine physician who did a number of changes around diet, and that actually improved her neurological symptoms. And then in 2022, the symptoms recurred. At that point, she was evaluated at the VA. An amyloid PET scan was done, showed plaque in the temporal, parietal, and frontal areas, generalized volume loss that was really focal in the right parietal area, and given a diagnosis of cortical basal degeneration, and really told she had a couple of years left to live and to put her affairs in order, and really no treatment. And so she came out here to Hollywood, and at the time, her MoCA, Montreal Cognitive Assessment Score, was 22 out of 30, really had focal signs of left arm rigidity, myoclonus, a lot of ignoring of her left hand. And then on lab work, she was ApoE4 negative. She had a lot of inflammation, MMP9 of 1500. She had a ton of toxins, so unprovoked. They were 400% higher than the 95th percentile in multiple toxins. And then the neuroquant did show a lot of the focal findings that the PET scan showed. And then we did find sleep apnea on a further evaluation. And so one of the challenges with this person was that resources were really limited, and we wanted to move things in the right direction, but we knew we couldn't necessarily do a lot of advanced therapies. And so we ended up deciding to really focus around a dietary program to help detoxify. We gave her the outlines of how to do the WALS protocol with detox. And rather than doing 9 cups of vegetables a day as a true Marine, she went and did 16 cups of vegetables a day. And just a lot of heavy exercise, a lot of use of the sauna, brain HQ. Instead of doing it once a day, she was doing it twice a day. You know, just give me the program, I'm going to implement it. Got the CPAP on board for sleep apnea. We put her on bioidentical hormones, high dose thiamine, and just modest supplement use, around trying to help the BDNF, mitochondria, and amyloid clearance pathways. Her family was able to find locally in the state that she lived in a group that was donating high pressure hyperbarics. So she was able to get up to 2 atmospheres in a multi-chamber environment. And then within 4 months, she basically, her MoCA had improved from 22 to 28 with the help of occupational therapy and physical therapy. She was regaining the use of her left hand. And I think really importantly, she had restoration of hope that remission could continue. And so one of the big questions in neurodegenerative disease is I see so many of my patients who everybody's worried about giving false hope. And the question is here, are we worried about false hope, or should we actually worry about false hopelessness? You know, what is our real duty as a clinician here? And obviously there's open questions about how long this remission can last for and what that can be, but there's no question that quality of life has improved for her pretty dramatically over this last 9 months with the help of a set of interventions. So when we look at the history of doing prevention for neurodegenerative disease, the Alzheimer's Association in 2014 or 15 was basically saying Alzheimer's is one of the major diseases that there is no cure. And so the message was there's no cure, there's no prevention, whatsoever. The first findings that in the literature that something could be done was really the finger study in 2015, which was not really Alzheimer's, it was vascular dementia. And there were 4 intensive lifestyle interventions of diet, exercise, and cognitive training. And the interesting thing in this is that it was a negative study in the major hypothesis, which was that it was going to improve memory. It improved executive function and processing speed, but memory did not actually improve with the finger study. There were a couple of other studies that were done around vascular dementia, the French study and the Dutch study, and those were also pretty negative studies in terms of outcomes on memory. Interestingly, at the time, the Institute of Medicine basically took that data and said, hey, there's really nothing we can do for cognitive decline, but the World Health Organization and the Lancet basically kind of put together a commission and a model that said that I think came up with some pretty important insights. Now, it was just the model, so it wasn't really based on much more research than what was happening in the finger study, but they showed that if you believed some of the lifestyle interventions that could be done, 35% of cognitive decline could be potentially preventable, because you have, a 2-decade onset of biomarkers ahead of symptoms. There's plenty of time to intervene. And most importantly, from a global economic standpoint, is that if you could just push out onset of symptoms by 5 years, the prevalence of dementia could be cut by half. So huge savings for the healthcare system with having a prevention mindset. And so that's, I think, one of the key insights already, is that having a different mindset about cognitive decline is really important. We tend to tell our patients cognitive health is like physical health. You don't just think about it as disease or health, it's a continuum. And do you want your brain to be more healthy and effective? And if you have a healthy cognitive reserve and you have better emotional health, you're going to have a better quality of life when your age begins with a 6, 7, 8, or 9. And so those, I think, are very good messages, and we're starting to see it move into the public domain over the last 10 years. Richard Isaacson, who was at Cornell and then came down to FAU for a couple of years, did some NIH-funded reviews on a very precision medicine framework for Alzheimer's prevention. Some of the research has been launched but not published in terms of outcomes yet, but it basically took the full literature and said, what could we do to intervene in Alzheimer's if we wanted to be aggressive about prevention? And so a number of lifestyle interventions, a lot of aggressive testing. The 2 areas that he did not focus on, probably because of just sort of the NIH funding, was basically chronic infections and the role of toxicants in cognitive decline. But I think that's been a nice, robust model. Interestingly, Dr. Espay out of Cincinnati has now put together, I think, a quite robust cohort and biomarker program the last couple of years, where his goal is to really create a Framingham type database for both Parkinson's and the dementias. And his thesis is really, we don't have nearly the understanding of the molecular biology that we need to. And so rather than just keep pushing these hypotheses like the amyloid hypothesis, let's just gather the data and really understand what the molecular phenotypes should be. So Dr. Dale Bredesen, who I've been working with pretty closely the last 6 or 7 years on this, really kind of came at this in a different way, where I think both him and, let's say, somebody like Rudy Tanzi out of MGH were looking at amyloid production and saying, we're actually looking at this the wrong way. Big Pharma is saying we should block amyloid, and that's actually, if we block amyloid sufficiently, we will get at the root cause of Alzheimer's. Their thesis was that amyloid may be neuroprotective. And in fact, what we need to do is get at the root causes of what's causing increased amyloid production. And so if you have that as a thesis, then a multimodal approach is going to be much more effective than a single modal approach. And so this came from one of Dr. Bredesen's papers, is he listed all of the criteria for a perfect Alzheimer's drug, in which you have 35 different, or if not 40 different aspects that it needs to affect biologically. And so is the answer going to be a single drug? or are we going to try to approach this with multimodal therapy? Obviously, multimodal therapy is a lot harder to study, but if the answer is there, then the open question is, should we study a multimodal approach? And then once we see that it can work, what's the next step from a research perspective? And so he started with really writing a few case studies. In 2014 were the initial sort of 10 case studies that he wrote up on patients that had come to him, and that he worked with other clinicians on really trying to do this multimodal approach. And there was sort of some significant improvement and in terms of their cognitive outcomes. A couple of years later, and we participated in the second paper, there were a number of people who were testing out these multimodal interventions, and he asked them to all contribute case studies to the paper. A case study that we contributed at the time was a gentleman who had a MoCA of about 13 and then improved all the way back up to about 29, and that was durable for about two or 3 years at the time that we submitted the example. It took a while for him to get IRB approval for a proof of concept study. I think the major intervention with the IRB was going away from one IRB and looking for another IRB that would actually, cover the study, because he got a lot of critiques that a multimodal intervention was just too impractical. But the paper that was published last year was 25 patients who were enrolled in a proof of concept study. There were 3 physicians that were doing this out of both the Bay Area and Oregon. And in those patients, you could sort of see the change in cognitive performance. So there was an improvement of 4 points on the MoCA, and that if you looked at historical controls, with no treatment, you would have expected a decline, and that certainly some of the monoclonal antibody studies were showing that there was still a decline, but it was less than what you would have expected from historical controls. So I thought this was a pretty strong signal to noise study. Obviously it's a small number, but it was enough to justify doing the randomized control study. Here's some of the data. When you look at changes in cognition, you can see that pretty much on the baseline, their Montreal Cognitive Assessment scores were 19 or above. There was also CNS vitals that were done in terms of checking cognitive performance. And you can see that those improvements are of the order where I like to say, if it's very clinically relevant, you shouldn't be arguing about statistical significance. You can see it from the back of the room, and you could see clearly there that there was improvement in cognition over that period of time. Very specifically, there was a set of people who did not improve or declined, and all of the patients who fell in that category, there was one thing they had in common. They were all in a moldy home, of which there were no resources to fix the mold in the home because the study couldn't cover it and the patients didn't have the resources to fix the mold. And some of the pictures, you'd see huge amounts of sort of black mold in the basement and others that just couldn't get fixed. And so we've taken that into account in the randomized control trial. Here's the changes in MRI volumetrics. They were all read in a standard way by a single reader and blinded. There was improvement in gray matter in patients in the trial. And then you can see there was not an improvement in hippocampal volume, but it was the decline was less than age-matched controls or patients who had mild cognitive impairment. I think credit to Dr. Bredesen is that they published the results of what happened in a private company called Apollo Health, and showing the experience of what was actually happening out in the real world. And so the predominant clinicians who were doing this were health coaches or chiropractors, not medical doctors. And you can see that even though some of the p-values were positive, did not nearly have the same strong signal that we could see in the proof of concept study. So this is really looking at an approach, as I'll talk about in the next few minutes, about what the interventions actually were. but I think it's important to sort of see that in, at least in the publications, that if you just don't have, if you just look at the whole cohort of people who are implementing this, you're not necessarily getting as good results. And you see that in the literature all the time, and the difference between effectiveness and efficacy. So we are launching the study now in July, and there are 6 sites. There's one in Florida here, there's one in Ohio, one in Tennessee, and then 3 in California. What we're looking for are 12 patients at each of the sites, and 8 patients will get an intervention now. 4 patients will get the intervention later, but they'll serve as controls during the 9-month period. And we'll talk about the intervention that they get, but then they'll get cognitive testing over 9 months, and then they'll also get volumetrics during that time to look at growth and changes in the brain through MRI. Yes, we are the Florida site. So there's a couple of things about the design of the trial, though, that we worry about. So we worry about the most about the control group. So which is all of these studies have a history of the control group getting significantly better than historical controls. And so that what we are also asking psychologically for patients is pretty difficult. We're asking them to be ready to commit to very aggressive intervention over a 9-month period and be totally on board with doing that. And then if they get randomized to the control group, we tell them, hurry up and wait for 9 months and do absolutely nothing while you're getting the standard of care. And so that is a big challenge. And so trying to actually kind of screen for the right people who will be okay with that is important. And then I think it's also very important with the clinician group is we've put together a set of protocols that kind of are going to prevent us from having our natural clinical instincts kick into effect with the control group, which is you would just very naturally want to talk with them about the changes to make and all of that. And instead, you have to just follow usual standard of care. And so that's really the biggest risk I see is in the control group and doing that right. The other thing that we are doing in terms of eligibility is we are sending somebody into the house ahead of time before patients are randomized to make sure that their house is not full of mold. It is okay to have some mold in the house that can be remediated or fixed. But if the house needs a significant remediation, we're not doing a randomized study of the effect of delays of remediation in South Florida, given all of the hurricane challenges that we have. And so that's going to be that's an exclusion criteria. So, but the control group improving is by far the thing that keeps us up the most at night. We are looking, though, not at a protocol in that it is not algorithmic at this point and saying, if the patient has this, then you give this. It is much more of a precision medicine or integrative medicine approach to basically measuring a set of biomarkers and then trying to improve those biomarkers. And so let's get into that. There's 2 or 3 mental models that I like to have in that to bring to the bedside in this. This is one of my favorites, which is really from a talk from Dr. Collins about the impact on health outcomes, where basically when you look at the whole health services research literature, basically healthcare only contributes about 20% of healthcare outcomes. Behavioral changes are another 30%, environmental is 30%, and socioeconomic is 20%. I would submit that as practicing clinicians, it is very hard for us to change socioeconomic variables at the bedside. It is certainly, we can all remember a one-off situation where we've done that, but certainly the healthcare system has moved in a positive direction over the last couple of decades in terms of changing behavior. And I do think that behavior can be changed much more effectively with the new technology and new biometrics that we have had. But the big gap in medical school training and in residency training is the role of environmental. And even though there's a lot of research on environmental exposures, actually translating it into bedside and getting that to change effectively is a big gap in the system. We talked a little bit about this, but I like this graph because it really is pretty comprehensive about all of the different environmental exposures and how that can affect what's happening with proteomics, metabolomics, transcriptomics, and how that leads into health outcomes. And I think in my practice, I find it just having a view that's pretty broad around how the exposome can lead to health outcomes usually uncovers opportunities that are missed because there's been some deliberate lack of emphasis on this. And we could save that for another time, but my thesis is really that it has to do much more with political, social, and legal reasons than it has to do necessarily with the medical reasons. This is a framework from Dale around how to think about cognitive health in terms of synapses. And so there's a concept of trying to, with the brain, thinking about this as an active network and thinking about whether you can hit the tipping point of creating more synapses, which is really being more synaptoblastic, versus whether you're pruning synapses and being synaptoclastic. And what we see clinically is that there really is a tipping point. Is that sometimes it's very rarely linear, that there's 1, 2, or 3 interventions, you might not see any changes. But when you hit maybe 6 or 7 interventions, you hit that tipping point where you can really do see clinically that patients do have some significant improvement in their cognitive function. And really the clinical challenge is to figure out the judgment of how to sequence those interventions and how to hit the tipping point and how to actually align that right, depending on their ability to implement protocols. So this is really the practical bedside model that we've developed on how to implement some of this. We think about cognitive outcomes really being at the top of the pyramid is what you're measuring and what we're holding as really our standard. We do think that most patients can have measurable improvement in their cognitive outcomes within 6 months of doing a protocol. The next stages below that is really looking at network function and potentially now that in the last year or two with LabCorp and Quest, we are starting to be able to measure some misfolded proteins like amyloid, phosphorylated tau better. And then when we look at root causes, we tend to divide them into 2 big buckets, energetics and immune dysregulation, which obviously connect with patients' genomics. And so in the study, this is what we're doing in terms of measuring outcomes. We're measuring a Montreal Cognitive Assessment Score and CNS vitals. We are measuring amyloid beta 4240 and phosphorylated tau, as well as doing a QEEG, which we'll talk about a little bit more later, and MRI volumetrics. When we get into the 2 buckets of energetics and immune dysregulation, there's a number of different categories. So within energetics, we're doing a thorough workup for micronutrients with the NutriVal. We're looking at lipids. We're looking at metabolic health with their glucose, doing a continuous glucose monitor. We're getting people into ketosis and measuring that with a keto monitor, measuring everybody for sleep issues, and then measuring hormones, thyroid, sex, and cortisol. On the immune side, we are looking at immunoglobulins, subclasses, a lymphocyte panel, measuring some markers of the innate immune system, looking at toxins and looking at chronic infections as well as the microbiome. And then we're using Intellex DNA as a genomics provider, and then also using True Diagnostics to look at epigenetics and methylation. So that's the testing that we're doing in this study. For all these patients, lifestyle interventions are foundational. And it's my hope as the research progresses that the way out of this is the earlier you get with patients, the more chances that just purely a lifestyle approach could be sufficient to have a positive effect on outcomes. And so on the lifestyle side, we do adjust it to where patients are coming from. But in general, the diet is kind of a paleo, whole foods, organic type of diet. We are using chronometer to measure adherence in the first couple of months. We're really trying to get a focus around healthy fats, olive oil, monosaturated fats, and getting patients into mild ketosis, defined as really being a measure between 1 to 4 on Keto Mojo. We are doing time-restricted eating, sort of 8 to 12 hours a day of eating, and avoiding eating 2 to 3 hours before sleep. It is a criteria to have a supportive partner as part of the study. And then they're working with a exercise trainer to get at least 150 minutes of exercise a week, kind of divided into aerobics, strength, and then doing mind-body exercises, and if the patient can handle it, to do high-intensity interval training. Everybody will get heart math as a protocol to help with stress and recovery. There's a real emphasis on sleep hygiene, using the Oura Ring to measure sleep, going and fixing indoor air pollution if that's an issue, and then doing Brain HQ as a neural exercise at least 5 times a week. So the lifestyle commitment is significant here. This would really take patients a couple of hours a day to really work this into their lifestyle. And then there can be a very open and logical question about, well, what's the most important part of this that I don't think we have a good answer on yet, but this was kind of the critical sort of minimum that we were shooting for. And so in terms of adherence, we're looking to have a good sort of 70, 80% adherence to this type of protocol in terms of lifestyle, and are trying to measure that week by week through the health coaches. So let me talk a little bit about the going down one more level and talking about the approach that we're using to support energetics. So on these 2 areas, when it comes to metabolic health, cerebral blood flow, mitochondria, hormones, micronutrients, the role of BDNF, and sleep and recovery, I put this up front because we're seeing that clinically, if we optimize these variables first, we're much more likely to get a response quickly. So addressing the immune dysregulation and toxins and chronic infections usually takes a lot longer to get an improvement. And that's a lot different than our younger patients who come in with mold issues, who might have a lot of inflammation and a lot of emotional issues and cognitive issues at the same time. Many of the patients who come in at 60 or 70, they have very high inflammatory markers, but they haven't realized that there's been a cognitive decline at all. And so, but if working on these 2 things, we try to front load this. And so, with the keto brain healthy diet that we talked about, everybody does get continuous glucose monitoring for at least a couple of weeks to give them insight into how their diet is affecting their glucose metabolism. We will look when a patient is ApoE4, we will understand sort of their cholesterol metabolism and whether or not, if we're trying to get their lipids down, what type of statin potentially to use, and using that to guide us, providing nitric oxide support for microvascular issues, hypercoagulability with some fibrinolytic enzymes. Everybody has their favorite way to support the mitochondria, but we're doing that. We are using both low, what's that? Oh, nicotinamide riboside. So low intensity through the B light, but at Resilier, we also are doing high intensity light therapy with an Aspen Pinnacle laser that really does get through the skull. And I'll show you 1 or 2 examples of what that does. And that's part of the study, as well as hyperbaric oxygen therapy. With hormones, most patients are getting bioidentical hormone replacement. We are supporting BDNF, or we're using the NutrIval to really guide micronutrient replacement, doing stress management, and then intermittent and extended fasting if and where needed. And so again, with all of these things, it's not that everybody gets all of the above, but these are just these are the interventions that are within the toolkit, if you will, at the clinician to use at his or her discretion. On the inflammation and immune dysregulation side, this protocol will be very familiar to all of you. Measuring and managing oxidative stress, managing inflammation, mast cell activation. If there's high iron, getting them into therapeutic phlebotomy or blood donation if possible, trying to improve amyloid clearance, making sure that we're addressing environmental exposures, and then doing appropriate gut microbiome support. And really with the whole notion of both toxins and chronic infections, at least the way that we're doing this at Rensselaer, and I think it's pretty consistent with the other sites, we save that usually at the back end, especially if patients are coming to us with a history of weight loss or they look really micronutrient deficient, because we've absolutely seen people take a very big step back if you start to treat the toxins and infections too quickly, and don't support them ahead of time. With network function, I think this is one of the areas where we've gotten some really interesting insights the last couple of years with using QEEGs and starting to use what's called neuromodulatory therapy. So there's two things that are in the study. At Rensselaer and in Tennessee, there will be the use of neurofeedback to really kind of help to improve network function. And in Cleveland, they are doing direct cranial electrical stimulation to improve network function. There's obviously some good geriatric care that's just done, making sure that vision is good, hearing is good, that the polypharmacy is not an issue, treating and managing depression. And then finally, on the genomics side, I think there's a balance between when using Intellex, it's oftentimes recommends things that would have been done anyway, but there definitely are a handful of genomic findings where it definitely changes therapies that would not be done unless you knew the genomics. And so one finding that we see a lot is DIO2, which is basically conversion of T4 to T3, especially in the brain. And so you can have an absolutely normal serum T3 and you can be DIO2 homozygous. And if you give Cytomel to the patients, oftentimes have a pretty significant positive cognitive response. And so that's where an example of where genomics could be, very, very helpful. On the QEEG, this is quantitative EEGs, where we're using software to help collect the data and then basically to synthesize the data so that we can see the brain network function in real time. And the QEEGs have really been the purview of the psychologists for the last couple of decades. I think the American Academy of Neurology did have a resolution 2 years ago that computers were allowed in the interpretation of EEGs. So it had been a sore point for a number of decades. But what I find with the QEEGs is that the analogy is a little bit like pocket handheld ultrasounds. Once you learn how to use a pocket ultrasound, you're like, why wouldn't I not want to use this going forward on patients? And so if you're doing brain health, the EEGs, the marginal cost of doing it once you're trained is very little. And so what we're finding with the EEGs is a couple of really important things. We're finding that brainwave function will change 2 to 3 weeks before there's oftentimes symptomatic improvement. And so that's pretty important, because if you're relying on symptomatic improvement and you're seeing these changes in network function, and there's that time delay, that can really be an issue if your mental model is symptoms correlate with the network function. And so we are able to see the impact of certain treatments like hyperbaric oxygen or light therapy or neurofeedback, within a week of doing some of the treatments. And so, for example, if somebody's coming in and they want to do an Israeli Afradi protocol with heart chamber hyperbarics, and they're saying, well, 60 treatments is a lot. Can I see if I'm getting better after 10? We can say, well, we can do an EEG and we can see where you are at baseline and in 10 treatments and see if it's moving it in the right direction or not. So the EEG has been very helpful now for us. Correct. So yeah, so we're using basically a cap. There's a fair amount of sort of technician skill that's necessary to get the data correct, and then it absolutely needs to be removed of artifact. There's definitely a little bit of art to doing that, and once that's there, the software is very good at interpreting that. Here's an example of some EEG changes. This was a gentleman who had a MoCA of 7, had some deterioration after overseas travel, and came to us. And what you could see here is this was at 4 Hertz. There was really excess activity in delta waves. So, the front part of his brain was essentially asleep. And he had taken a severe decline from his prior state. And after a week of light therapy, this is what his brain looked like a week later, and there was improvement basically from the MoCA of 7 to 15 at that time. And what light tends to do is it tends to help mitochondrial function. The analogy that I do give to patients, this is red light. And it is at a higher wattage, so that when you look at some of the cadaver models that there have been of looking at light therapy, the skull will block out about 93% of the energy. And so I don't think that the traditional low intensity photobiomodulation is really getting through the skull. It may be working in other ways, like through the blood vessels, and potentially the nasal diodes are better because the skull is thinner in those areas. But what we are seeing is with the high intensity is that you can absolutely affect mitochondrial function in the brain very quickly. Now, it's almost like a car that you're jump-starting with and jump-starting the battery. If you don't fix the battery, it's going to need multiple jump starts. And so it's not a permanent answer, but it does absolutely give us a sense of, can the brain kind of be improved, if you will. Yeah, we won't normally sort of take somebody who is a sort of de novo, not and not fully worked up before we would do that. Yeah, absolutely, absolutely, yes. But here's some clinical observations that I have around using this approach in practice. We do see that we can get measurable improvement within 6 months. And in fact, we really do design our protocols now to try to get that within that period of time, because I think it's very hard for patients to do major changes in lifestyle and not see that it's actually kind of yielding benefits. So it's as much, I think, for a psychological reinforcement as anything. There are definitely some poor prognostic factors. So having significant brain atrophy, so defined as having a volumetric percentile that's below 2 standard deviations, so less than by the 5th percentile, is a very poor prognostic factor. Decline where the MoCA is less than 14. Having frontotemporal etiology, we definitely see people improve less on on those protocols. Lewy body tends to be, and vascular tends to be similar to Alzheimer's. Having no partner and family support is a huge risk factor. We've seen patients get better, but it's definitely harder. If we can get improvement in the first 6 months, then I think that patients can better articulate their values and preferences around how much work they want to do. And I do think that becomes an issue as patients get older, and it's a little bit like how much of your life is spent sort of doing a protocol that's designed to sort of keep you healthy, and those are very individual, focused things. And the biggest bottlenecks that we've seen outside of these prognostic factors when patients don't get better is if there's a toxic burden that's just hard to really detoxify people completely, or chronic infections, or there's a mold issue that they can't get resolved. But we do see that significant regrowth in neuroplasticity is possible. So I'll give one other example on this. It's case number 2 of somebody in their early 60s who came to us with really having cognitive issues, poor sleep and headaches, a lot of joint inflammation, and it had breast implants for the last 20 years. They had a redo 5 years ago. They also had mold exposure. And so their CNS verbal percentile was in the 15th percentile, and there was significant atrophy here. So the cortical gray was in the 3rd percentile, and we did do advanced toxin testing with a company in Germany called IGL, which actually allows us to look at silicone, and we can see that there was silicone adducts that were attached to the DNA, and there was high amounts of silicones even after the explants, sort of a year after the explants. And so the interventions really were explant, environmental remediation. She did get IV phosphatidylcholine, hyperbarics at home, a V-light, and neurofeedback. And just to get a sense here, the cortical gray went from the 3rd percentile up to the 38th percentile. The temporal lobe grew from the 2nd percentile to 23rd, and the parietal grew from the 12th percentile to the 75th. Early 60s. Yeah. And then the IGL over multiple times, got to normal reactivity with no residual DNA adducts. And her MSQ dropped from 124 to 16. So you could definitely see improved neuroplasticity once you got the toxins out. Sure. We used basically a combination of using IV phosphatidylcholine, and at the time there was butyrate that was available. Butyrate has not been as easily available, since it's been used for other neurodegenerative diseases, and we were using IV at the time. So you could, yeah, and so and as well as like a Quicksilver type of protocol as well. So it was a combination of both. But there were definitely multiple rounds of detoxification. This was not a simple, 3 weeks and we're done. So this course was over about an 18-month period of time. So, please. I haven't seen direct data. Do you know of the direct data to do that? I mean, it makes sense that it could certainly help. Yeah. Uh-huh.
Those slides never became available to us.
Yeah.
But different things like that showed up in post hyperbaric.
Yeah, I'll certainly take a look. That would be great information to know. Yeah.
I can reach out to Alfred Johnson in Texas. He does pretty much all hyperbarics, and I'll see what he has. He wasn't the presenter, but I'll see.
That'd be great. Thank you. A couple of just comments on where we are. So I think it's important to understand what I'm saying in this talk today. I think there is a strong signal to noise ratio out of doing multimodal interventions from cognitive decline. I think that we absolutely have to prove it through better research. Our hope is that actually the research that we're able to do in this randomized clinical trial will then stir up a lot more research at scale to really get into key questions about how to implement this. But I think that even now, if we say that success from the randomized control trial would be just to get the results that happen in the proof of concept and have the controls act like historical controls and not have them act like controls that improve as much as the patients, that would be a huge success. And if that's the case, I think there are really some pretty profound implications on the healthcare system, where I think with neurology, if multimodal intervention is really a significant path to improvement, then really what you need is somebody who's more of an expert generalist, somebody, because so much of this is just getting patients better and getting a lot of multiple physical symptoms better. I think when it comes to looking at outcomes, there's a huge improvement in quality of life with changing cognition. And it's not just, preventing dementia, but what is the value of basically staying sharp in your 60s and your 70s, and then just pushing everything out in another couple of decades. And so really understanding the impact on quality of life. This can't be a healthcare resource decision alone. If you look at lifestyle interventions, it's deployment of personal budgets, and we have to have a much better discussion of how potentially to use personal budgets. When I talk about this with medical students, the immediate question is, okay, well, what are you going to do about disparities? I'm like, well, we're first looking to figure out whether this works, and absolutely we need to think about that. But here's the thing about the economics, is that it's very few interventions are cost savings. Interventions can be cost effective, but this does have the potential to be cost savings to the health system. And so I took a model that's recognized as being a standard cost health economics model for Alzheimer's. It's owned by some researchers in Sweden, and it's called the IFMCP model. And we basically just kind of took two sets of assumptions. One is you do 5 years of treatment and you get 70% reduction in progression year over year, and $15,000 per treatment a year. So that would still be, $75,000 of treatment over 5 years. And that gets to a cost effectiveness of, $33,000 to $25,000 a year, which most health systems would easily pay. And if you take it and change some of the assumptions and say, well, what does it take to be cost savings? You basically need to have 10 years of treatment to have an 80% reduction in progression and to drop the cost down to $6,000. So those are pretty steep, steep thresholds to kind of come over. But at that point, you actually save the healthcare system dollars. And this didn't really take into full account, I think, all of the costs within assisted living and nursing homes. But I think two logical implementers of this type of protocol would be Medicare Advantage plans that potentially have some long-term risk of their patients, or continuing care retirement homes, where they're kind of thinking about the model of, are the patients going to move into the nursing home or not, and bearing the risk of the nursing home. I think both of them would look at these economics and say, hey, this is actually something interesting to start to potentially redeploy personal budgets. They did. I did not know that. Okay. Mm-hmm. Yeah. Well, and so that's great. And then the real question will be when they start to change what's on the, what the kitchens are putting together, and changing the diet is going to be the real, the real big thing. And then to just kind of conclude on here, as I always do like this quote, as I got into the space, I never liked sort of being thought of as alternative medicine. I do think that sometimes what's kind of out there in terms of thinking that it's non-conventional, my conclusion is there are really legal, political, business, and social reasons why this is happening, as opposed to really the science. And so hopefully what I've showed you today should be reasonably provocative about where the opportunities could be. But I think most of the priors that we're kind of bringing into this are all based on very, solid conventional medicine principles, which is we're trying to change biological systems. We have objective biomarkers that we're measuring, and we're using that to follow that, and we're trying to really get to a threshold approach. So with that, I'm certainly open for questions.
As I get the microphone, I get to start.
Yeah.
First, a couple thoughts. First, don't remember where you were in this time, but Irma and I were there when they tried to move HIV care out of specialty clinics and into primary care, and the outcomes were just not good.
Correct.
Right. And then there was a beautiful paper that proved that if you actually knew something about this, you had better outcomes.
Right.
And it forced the insurance industry to start reimbursing the specialty clinics again. And that was an important point, that to your point, that perhaps you're going to prove that you need specialty clinics to be able to manage this until there are, biomarker guided, easier algorithms to let other people play in this sandbox.
Without a doubt. I mean, this has been the hardest medicine that I've had to practice.
Yeah.
And I think there is a lot of judgment, and I don't think we get out of the judgment area anytime soon. And so, I've been on the other side in the business decision making of, how to scale some of these clinical things. And usually what happens is there's a desire to remove personal judgment from the front lines and to make it algorithmic. And where we are in here, there's no, I think, ability to make it pure algorithmic anytime soon.
So we're struggling in the same kind of way, but using different tactics. So in the systems biology modeling that we do in complex illnesses, we can say clearly that a single intervention on a single point does not change anything for very long. That you can move people out of their homeostatic space, but they'll swing back into it if you just push one button. And then we have in our modeling the ability to say, if you push 2 or 3 buttons and you're pushing the same buttons, that we have the potential to move people up over the mountain and drop them into a different homeostatic space.
Right.
And then it'll stick. So we have this beautiful model. And then we did an animal thing that seemed to prove the model. And we were able to get funded. So, which is amazing that we have phase 1 and perhaps phase 2 funding to pursue these multimodal treatments that came out of systems biology modeling. But even in our modeling, there's clearly subgroups, and we can discern down to about an N of 10 we need about 10 people's worth of data to model out per subgroup. So men and women are different, postmenopausal, premenopausal is different, so on and so forth. And the models fall out that way. But it's been a very hard sell to finding the funding. And then my last comment is, if I were looking for the controls in your group, I would be at a standard memory clinic. I'd just be saying, I'm going to take 78 people in the memory clinic, and I'm going to follow their outcomes for 9 months against our outcomes. It's not randomized, but it is
just having a historical.
But it is a true control group. I mean, I'm not sure that. I think you're going to run into all kinds of trouble with that control group. Yeah, because they're super motivated to get better, and they're going to find their own path. So, but that's the way it always is.
Well, I think a couple of thoughts around the control group. I'd certainly like to talk about maybe the value of getting the historical at the same time. But what we at least are doing with all of the patients, there's not enough funding to do a crossover, but the patients are getting told that they have the opportunity to do it later. And there is a dropout penalty if they start changing their behavior. So there is at least a little bit of a negative reinforcement there. And we only did that because we were really trying to figure out what we could do to preserve the integrity of the controls.
So,
Dr. Tanio, thank you so much. It's amazing presentation as always, and so much information. Besides Alzheimer's disease and patients with who come for this record protocol, you use this our patient with chronic fatigue syndrome, with post-COVID. The major problem is the cognitive symptoms. We all complain about cognitive symptoms. You are applying these interventions to our regular population, correct?
Yes.
And it's successful, right?
Yes.
So it's and to which extent everything, or just what is more helpful for practically for our population for chronic fatigue and post-COVID? What do you found something more helpful, or you should actually go all the way with everything?
No, I think, I mean, that's a tricky question, because I do think that it's always trying to start with people's sort of values and preferences, and then trying to figure out the issues that you have that patients are making, results on. So, for example, saw somebody yesterday who's had long COVID for a good year, and that's just kind of been under our care for about 3 months. And, she has been able to, with treatment of mast cell and just and careful coaching on avoiding crashing, and treatment of her POTS, she's now avoided setbacks. And so she's been able to, feel much better. And now we're gonna start the hyperbaric, oxygen therapy. She's gonna get it at home. She's in Los Angeles. So I think we use the same principles. I'm not sure there's one or two things I could pull out and say, okay, well, in chronic fatigue, we're doing this differently. But I do think that something that oftentimes the concerns of patients are quite different, so.
With Alzheimer's disease, you have really more unified population. Chronic fatigue has a different etiologies, so you have to bring different tools.
Well, I think I think so. I like to now think about it as cognitive decline, because I think the one thing I didn't finish in the story at Hopkins was the thing that really got my attention was the neurologists were saying, we're seeing all these patients in their 50s, and this was in 2015, that we never saw patients this young before. And so that there's sort of different types of cognitive decline that are happening. And I do believe that, with COVID and with the toxin exposures, you're going to get a much higher percentage of people presenting in their late 40s and 50s than you did 10 or 20 years ago. And so I think those etiologies will look quite a bit different than let's call it the standard Alzheimer's ones. So
Thank you.
Irma. Yeah. So my view on hyperbarics at this point, given where the literature is and I had a discussion with Afradi about this, obviously if you talk to him, he'll be 2 atmospheres is real hyperbarics, everything else is fake, and it's a very, strong perspective. And I think the research that he's done is about as strong as there is, because they solved the placebo issue. I do believe there's a big difference, I think, clinically between 1.3 and 1.5. Now the FDA only clears things to 1.3. Canada clears soft to 1.5. So make with that what you will. So it is possible for people, ex-US to get 1.5 and I think have a pretty good response. But I haven't seen it in research. But I think if patients, all else being equal, I prefer higher pressure. But certainly, like Irina talks about, like, with chronic fatigue and mast cell patients, there's a lot of mast cell patients who can't handle higher pressure, and they tend to do fine in lower pressure, but it takes longer to do. And I completely agree about your point about cost. My belief is, from a research side, you have to decide where the thresholds are and where you can get results. And then, I do think the question on the table is, can you engineer out costs? And I think you can engineer out costs pretty dramatically if you start to look at this. Like, you could, our vision would be, hey, you have all of these retirement communities that are, out here in South Florida. What would that look like if you engineered a community to be healthy? You would have healthy environments. You would make sure that all the housing decisions, led to clean air. You would try to encourage, gardening within the near the house, and you would try to get diets better and exercise. And I think you could absolutely see a pretty cost-effective intervention that would have a pretty dramatic effect on prevention. But you would still have those cases that need more intervention to get to the threshold. Well, there's no question that this is a contact sport, and that I position this to patients that they are the ones that are driving the protocol, and that we're helping them do that, but it's not as simple as here, take these three medicines. And so what's really important is for people to understand ahead of time how much work is necessary. And then we do have some realistic conversations if people say, well, I can't do this, I can do, this aspect of the protocol. And I think the hardest things that we have found sort of clinically is, let's say, somebody comes in with a MoCA of 12 or 11, and they want Hail Mary, and they want things to be reversed. We at this point have a completely separate consent form. There's the research is not really focused on patients that are below this, and are very clear about, the time duration and that. But I do think that it's not an all or none. So let's say somebody can't exercise because they have, some medical issues that prevent them from getting, rigorous exercise. Can they still get full benefit from a protocol? Absolutely. And we might try to do, some nutraceutical support to attack BDNF in a different way than exercise. We think that exercise is the best way to move BDNF. But and I think there's an art to having that conversation. I think it is it's very hard for people to understand the value of potential improvement in cognition, right up front when they're kind of talking this through. And what we find is after people have been doing it for 6 months, they can see some improvement, then I think they're more easily able to make trade-offs, if you will. But we very much believe this has got to be driven by their values and preferences. And then also when we're having that discussion, it is very much full informed consent that this isn't, been shown in a randomized controlled trial. I like to call it an asymmetric bet. You have 6 months to see if this is going to work. The real downside is, for your health, you might feel healthier. You might have lost some weight and feel better, but it might not have affected your cognition. There's definitely a financial, aspect, to this as well. Well, I think if you start to frame cognitive health and you put, so this is where the lens kind of comes in. And I'd say, let's think about cognitive health and let's use the lens of physical fitness and look at cognitive health that way. So the physical fitness, trend really wasn't driven by medicine. It was really driven sort of by, performance and other types of aspects. I think if you look and say, who's a market right now for improvement in cognitive health in their 40s or 50s, it's a lot of executives and knowledge workers who say, hey, I'd like to actually improve my brain performance. And we're partnering with a software company around their employees around how to actually improve their overall cognitive and emotional health. And so I think there's a huge opportunity to improve brain health in younger populations. We have right now 1 out of 4 adults in the age of 30s or 40s who are taking an antidepressant, for example. That number has doubled pre-COVID to post-COVID. So there's definitely some things that are wrong with our brain health that can absolutely be addressed by some of these principles. And so with a more accurate biomarker, I mean, this is where so much of psychiatry in the past has been dependent on symptom reporting. And what we need is more objective biological, measures of what's happening in the brain. And so I do think that, we tend to not be dualistic about thinking about, mental health and physical health, but look at, both as different sides of the same coin. So I think that would really be the way to start. There are clear pain points in people in their 40s and 50s where you don't have to view it as a prevention campaign and say, you're going to get some theoretical benefit when you're 80. You can say, you have pain right now that if you work on this, you can improve your health, and we can get you off of the antidepressants, and we can have you be more relaxed when you come home from work.
Dr. Tanio, one more question about modalities again. You mentioned light therapy. I recently was in a conference and it was one person using in ophthalmology special light therapy device, and he postulates that it's actually help with mitochondrial function. In his samples, the person with myasthenia gravis ptosis was decreased. How you use light therapy?
Well, I think one of the challenges in a lot of the integrative space can be that a lot of these modalities are not sufficiently tested, if you will. So,
oh, sorry, but my example, he's actually not integrative. He's ophthalmologist in London, and it's a part of the regular Western medicine,
right.
but he's using it, right?
And what light modality is he using exactly?
I said it's a special lens, red lights.
Yeah.
It's very not available actually.
Yeah. Well, it would be hard for me to comment then on his, but what we've looked at light is that there's clearly having some activity in the mitochondria. You can clearly see what's happening in the brain sort of before and after. And you can get some very precise cause and effects. My colleague Bob Hedaya has written and published a couple of case studies of patients with prosopagnosia where they couldn't recognize faces, and then with very targeted light therapy, we're able to now recognize faces, and that lasted sort of permanently. So you can definitely jumpstart certain parts of the brain. There's been a good safety demonstration in a couple of the stroke randomized trials. There's a safety database on the use of high intensity light, and there were no major adverse side effects. We do screen everybody that they require an MRI and a screen for any kind of arteriovenous malformations, or if anybody's had anything neurosurgically with the vascular, we stay away from that.
And you guided it with a quantitative EEG?
Correct. Yeah. And you can definitely see, you can do good N of 1 care to see the before and after what happens with the neuromodulatory therapy.
So to rule out, we have to have MRI to rule out any acute or chronic pathology before we start with light therapy. It's transcranial, right?
Correct.
Okay, thank you.
You're welcome.